Greetings! My name is Sharon Dizon, and this is my presentation for course Leading People, Processes, and Organizations in Interprofessional Practice. This presentation, entitled Collaboration and Leadership Reflection Video, is geared to answer a few objectives in order to foster best practice interdisciplinary collaboration. The first objective is to reflect on an interdisciplinary collaboration experience, noting ways in which it was successful and unsuccessful in achieving desired outcomes. The second objective is to identify how poor collaboration can result in inefficient management of human and financial resources, citing supporting evidence from the literature. The third objective is to identify best practice leadership strategies from the literature that would improve an interdisciplinary team's ability to achieve its goals, citing at least one author from the literature. And lastly, be able to identify best practice interdisciplinary collaboration strategies to help a team achieve its goals and work together, citing the work of at least one author. As a skilled registered nurse, it is without a doubt that I work with various disciplines in the hospital setting. One notable experience I would like to share while working in the hospital was when I and a physical therapist shared a 78-year-old rehab patient who has undergone a total knee replacement. As a nurse, I assist the surgeons in providing care for musculoskeletal system problems, monitoring patients' vital signs, addressing and treating wound dressings, and administering pain medications in a timely and efficient manner. Additionally, I provide patients with education on how to be more autonomous in terms of aftercare and improving mobility following surgery and upon discharge. My experience with working with a physical therapist or PT has been exemplary. I believe that the PT and I share the same passion for aiding quality patient care. The PT also has a great bedside manner, which the patient admired. One significant intervention that the PT suggested was to make the patient ambulate 8 hours after surgery. I am aware that knee rehab patients must ambulate right away. However, I thought that 8 hour status post-surgery was a little too aggressive. I asked the PT what his rationale was, and he stated that the patient endured pre-surgery physical therapy and that the patient should be able to tolerate dynamic activities right away. Though I was seemingly ambiguous, his rationale made sense. I expressed to the PT if he would let me assist him with aiding the patient to ambulate, so that I may be able to observe, learn, and track the patient's progress on my end. The PT gladly agreed. My role during the patient's physical therapy session was to be an extra set of hands for both the patient and the PT. I was able to assist the PT by providing the patient with postural stability and safeguarding the patient's balance due to pain guarding. During the interventions, the PT and I also provided words of encouragement and motivation to the patient, and we were both on the same page as far as educating the patient about favorable outcomes. In my experience, I can say that the efficacy of patient recovery is directly proportional to unanimous and consistent interdisciplinary patient education rendered. It is believed that when two or more disciplines communicate and generate a sound judgment or decision, it not only fosters patient-provider trust, but also provides the patient a sense of hope that they will get better. Overall, My collaboration with the PT on this specific patient had very favorable outcomes. Through this process, I was able to enhance my knowledge in the physical therapy aspect through evidence-based practice. Additionally, the patient has been discharged 1.5 days status post-surgery, which results in decreased patient length of stay, or also known as LOS. Through collaboration, we were able to cut down the average LOS in total knee replacement patients by 50%, thus proliferating efficient use of financial resources. Now, let's proceed with the Villa Health scenario. Last year at Villa Health's Clarion Court Skilled Nursing Facility, there was a new implementation of HealthX, which is a novel electronic health record, which I am going to refer to as EHR. As we can imagine, any new changes could face criticism and pose potential issues. This was the case for Clarion Court Skilled Nursing Facility. During my time at Clarion, I was able to observe and hear from a few administrative representatives as well as care staff members who happened to be nurses like myself. There were clearly a lot of pointing fingers and blaming among the staff, leading to poor collaboration, which in turn affects the overall quality of their provision of healthcare. In literature by Stewart, 2018, poor collaboration can lead to unsuccessful communication, patient discontent, misdiagnosis, hindered treatment, medication errors, increased mortality, and self-mutilation among practitioners in the workplace. To prevent all these potential consequences, we must pause and look at our values. In a study conducted by Skarian 2020, it suggested that the framework of solving any problem is through values. It consists of 4 steps: problem analysis, selection of values as background for the solution, search for alternative ways of the solution, and the rationale for the solution. Adapting this method, we can determine that at the Clarion Court Skilled Nursing Facility, the administrative staff is faced with corporate pressure in minimizing costs and expenditures in appropriate EHR and its corresponding training. We can also see that the care staff are faced with challenges navigating the EHR, affecting their productivity and safety with the provision of care to patients. However, one commonality they had was their values in excelling in their line of work and values in rendering the best quality of patient care. Using the core values of Clarion Court Skilled Nursing Facility workers, we can reframe their mindset by allowing both administrative and care staff to actively engage in peer-to-peer discussion or meetings, focusing on identifying values that are related to personal integrity, identity, guiding an individual's perception, judgment, and behavior. I believe this process will reduce the friction among workers as they are taken back to the idea of what matters most to them, in this case, patient care. Through peer-to-peer discussions, we can also have a constructive way of identifying the strengths and weaknesses of each employee, and from there generate rigorous training on the new EHR. This way, they can determine their own individual codes of conduct for their respective jobs, transpire the process among groups of colleagues, and promote accountability and autonomy. John F. Kennedy once said, "One person can make a difference, and everyone should try it." I really live by this statement in the workplace because at the end of it all humans value values, and values bring out the best in each and every one of us. Thank you.